All right, so Amir Abdul-Jabbar here. We're here with Chris. Go ahead and introduce yourself.
I'm Chris Seidel.
One of our new fellows here for the year. And where are you coming from?
I trained out in Pennsylvania at Wellspan, orthopedic.
Wonderful. So we're doing a lateral interbody for you today. Hold on, hold that for me for 1 second. So just kind of running through our lateral steps. We've kind of pre-prepared some of this for you. If you want to pan over to our AP and lateral views on the fluoroscope, you can see we've kind of tried to get towards the 50-yard line of the, so that's our lateral. So that's an AP, we want the lateral up as well. Try to get our wire in the 50-yard line, and then now we're trying to get this retractor to work for us. So obviously we'd be using directional EMG to try to map out the plexus, probably one of the most important parts of this procedure. And we'll go ahead through our discectomy. So go ahead and open those tubes for you. Okay. And then if you want to lock that in place. We are using a carbon fiber setup, and it looks like we do have a little bit of a flimsy arm here, so we'll do our best. Give us a shot. Yeah, so that's kind of moving a little bit south on you. So we're trying to get those markers centered over a disc space. Shot there. Yeah, it does not want to stay with our tube. Can you hold this retractor for me? And I'm going to loosen this up and let those arms stay closed. And then if you could point that, can you see how we want to come a little bit further north? So that's actually south. Shot. There we go. Hold that right there.
I have it.
Mm-hmm. And do we have lights for this retractor blade? So one of the things that I like to do when we're doing laterals is you only want to use as much retraction as you need, trying to minimize that tension on the plexus. So the beauty of this lateral approach is it's very minimally invasive, very little blood loss if you can do it correctly. So next step, shot there. It's still wanting to creep south on us, but I think we're okay. So one of the things we can use this shim. Give us a shot. Okay. And now go ahead and mallet that down for me. Shot there. Great. All right. Mm-hmm. And then we're going to get our lights going here, and hopefully we can take a look down and see pretty well what we've got. All right, do we have a camera overhead? Awesome. See if we can line that up a little bit better. See down the pipe here. Mm-hmm. So go ahead, Chris. There's going to be you'll be centered over the disc space. Next, we'll do our annulotomy. And what we can also do is check a lateral to make sure we like our position anterior, posterior.
Okay.
So why don't we do that?
Thanks.
All right, and that's, so just to orient you guys here, this is our shim kind of right around the 50-yard line. You may want that just a slight bit more posterior, but for demonstration purposes, I think this will work well. Just see that your retractor here is centered a little bit on the inferior vertebra. So as you're working through those tubes, you want to make sure that you're coming up a little bit north. Let's come back around to the AP, please. Mm-hmm. It's not going to actually splay. So can I have a suction, please? So go ahead and look down there and go ahead and do your annulotomy.
Okay.
And pituitary, please. All right. And I don't know if you can see down, this is not always the easiest demonstration to show. We'll go ahead and take off that lateral aspect of the annulus. Great.
Okay.
And I would love to give you a better view here. I know that's not so easy to see, but I'm going to try and adjust this so you can actually see our field, because it's the fun part of the demonstration. So next we'll take our cob, and you want to take this right along the end plate, both cephalad and caudal. So as you're down, give yourself a shot. So you're down on body a little bit there. If you look at your shim, that'll give you a guide to where you want to head.
Shot there.
Great. One of the things that I teach the fellows for this move here, as you get close to that contralateral annulus shot, keep going. You want to choke up on this cob to make sure that you don't plunge. One of the pitfalls of the lateral approach would be your retroperitoneal injuries, either bowel injury, ureter,
Shot.
and that can actually happen on the contralateral side as well as the ipsilateral side.
Shot.
And if you could drop your machine just a touch, we want to see that we're all the way across that contralateral annulus.
Shot.
Great. All right, now do you have a box cutter? And so we would do that on both the end plate above and below. Because this is such a healthy disc, we're just going to go straight to a box cutter to try to get that disc material out.
Shot.
I like this box cutter device because it does your discectomy as well as act as kind of a first dilator, and that can actually really work well on a very collapsed disc to give you some more disc height.
Shot. A little bit further. Shot. That's all.
Great, go ahead. And so we do have a very robust disc here, so you're probably going to need a pituitary, maybe a rasp to get that disc material out of your way.
Okay.
Can give you a hand here. I'll keep going with the pituitary. You're going to really want to take as much of that as possible. Okay. And then here's our rasp. So if you have a nice entryway, you should be able to just use that rasp on the end plate to try to clean off that disc. And we'll go to our trials next. Give us a smaller trial first.
Shot. Shot. Shot.
And as you're coming across this trial, you might find that, keep going, that you get some more disc loose. So taking another look down through the annulus to make sure that you've gotten all that disc material, and that's probably what's hanging you up now. Good. So go ahead and come out. And if you can look at that last shot up on the screen, that's going to give us our sizing for our different implants. So what do you guys have with sizes here?
This size right here is 14 millimeters. It's fairly high.
No, I'm talking about with the length. So can you point to us where the different markers are that it's going to give us the appropriate length?
30, 40, 50, 60.
Okay, great. And so what do we have available for us today?
We have 50.
Perfect. All right, so I'm just taking more of this disc because I can see that there's a lot of disc here, which is atypical because usually these cases are very spondylotic and collapsed, and we're using this to get our reconstruction of the anterior column and either getting lordosis or correcting that coronal deformity.
Okay.
All right, let's take the next size up for the spacer. And can I actually get that 15 blade again?
Yep. Can you
That's like a 12.
And one thing, just because I know we started a little bit close to that middle, you want to stay right off that posterior blade. So when you're doing these, you really want to stay posterior. Let's do a standard. So today we've got a 14 millimeter height cage. Again, because this disc space is relatively spared compared to what we typically be doing, I would say that's sometimes larger than we're able to get. Yeah, go ahead and mallet that all the way across because you want to make sure that it's free enough so that you're going to get across that apophyseal ring on the contralateral side.
Shot. Go through.
Ooh, yeah, there we go. I think we're across.
Yep.
And so, again, if there's anything left over, you do want to make sure that these end plates are clean. In this case right here, there's going to be a lot of disc that may get in our way. You can see that this keeps coming out. So if this were a real patient, I would spend a lot of time making sure that you've got your discectomy done well so that you can get your fusion across that space. So let's now go in with the cage. And again, we're working right off that blade, so I'm going to shift this so that it's a little centered up better for you.
Okay.
And it may be tough to get it, because it's a large cage that we're dealing with, it may be tough to get it started. Do you have shims in case we need them? Go ahead.
Can you give a shot so I know I'm in the right place? Yep.
Go ahead.
Shot.
Hold on one second. So take a quick look down there. Looks like you
Sliding
may be,
anterior.
heading off the front.
Mm-hmm. Calling the blade.
Mm-hmm.
There you go.
Let me get that for you.
Mm-hmm.
So it's going to be right back there. Do you have any smaller size cages? Yep. So we made it tough on you today. You're getting
Shot.
14 or nothing.
Sliding anterior still.
Yeah, so we're,
Yeah.
yeah. Just come back up the blades here.
Mhm.
Let's see if I can help you out a little bit. Let's go in with the last trial. So I don't know if you can see it. You really just want to make sure. You see the cage?
Here's the cage.
So because you're fighting it a little bit, go ahead and hit that for me. Hold on, shot. Okay. And shot again. Okay, go ahead. Hold on. And so it is wanting to fall anterior, and one of the things that we worry about now is releasing that ALL. So always in your armamentarium, that's not always a bad thing. You just want to have a screw because that can destabilize and go through the front. So we're not totally. Let's go back in with the last trial, and I really want you to aim posterior with it. That's going to help us get your trajectory. And do you have a large kerosene?
Shot.
So now you can see you're probably making a new path, right?
Yeah, I'm definitely going through posteriorly more than I have before. This soft tissue is
Soft tissue in there.
yeah.
And again, I think because we're doing this as a demonstration, we did not do a robust enough discectomy. And if you find that you're doing that in the case, you're seeing that you keep getting pushed in the wrong direction, it's usually soft tissue that's going to be in the way and preventing you from getting into the space that you want to be in. Wonderful, thank you. So this is like a 2 millimeter. If you have anything bigger, that would be great. And let's see if we can get this jumbo cage in. This is no easy task here.
There might be some disc posteriorly there.
Yeah, go ahead and grab your cage again.
Okay. You guys have that cage? Oh, where's the cage?
Oh, here it is. Sorry. You see mallet?
Yep.
So this cage is wanting to fade anteriorly. Shot. But go ahead and drive that in. I don't think it's too far off the front. You can tell he's an orthopedic surgeon the way he swings that hammer. Okay, shot. You're getting there.
Yep. Just good.
And again, that's really going to be soft tissue there.
Yeah.
Let me see if I can. I don't know that it's going to go any further. Shot again. Oh, we're getting there. Let's just come around to a lateral just for demonstration's sake. We could bang on this thing all day. How do you release this? Okay, thank you.
So it looks like you guys are making good progress there. And I think, Amir, your comment
Bob, I think you might be saying something, but we can't hear you in here.
Ben, can you get me projected in there?
All right. And so come back towards you just a touch. And so you can see what we were talking about. We're very anterior on that disc space. Again, if we were having this placement, we would probably want something hyperlordotic maybe with fixation into the end plates, because you can see we're probably releasing that ALL with this technique, which again, if you're looking for lordosis, is a very powerful technique.
Yep.
So Bob, yeah, we can't really hear you. I was wondering if you had any questions.
I was hoping can you hear me now? Yeah.
Not really.
Oh, all right. I'm walking over.
I can't hear you. I can hear you.
Oh, you got me now?
Barely.
You
but
got me now?
I can hear what you're saying.
All right, good. So, this is a cadaver lab, and I think the comment you made earlier about the plump disc is a big part of the issue here, and I appreciate the efforts you guys are making. I particularly appreciate Dr. Seidel's strong right arm. I don't think any of us would probably be quite satisfied with that cage location, but like I say, it's a unique and a teaching situation. So thanks very much. The question I had was, you commented during the procedure about the risk to the ureter and the other vascular structures and bowel. What steps do you take to prevent or reduce those risks?
So I think one of the biggest parts is the preoperative planning. In the MRI, you'll be able to see there can be vascular anomalies where you can see where our cage is very anterior. You could very easily be going straight through a vessel in some patients if you don't pay attention to that. So something to be very careful of. Again, if we were fading forward, you knew there was a vessel there, you absolutely stop and reposition. Also, people, especially in our thinner patients, can have a very small retroperitoneal space. So being careful to start posteriorly, make sure that you're in the retroperitoneum, not in the bowel, to prevent bowel injury. And then also that's going to drag the ureter across your field if you don't really develop that retroperitoneal space. And then the contralateral side as well, just being controlled with your instruments and being sure not to plunge.
Right. I think that all makes good sense. I think nicely done, and really appreciate you guys' involvement. Thanks so much.
Thank you.
Oh, we have a question from the audience here.
Yeah, what's your thought process on patients with prior abdominal surgery and doing a lateral approach?
So prior abdominal surgery theoretically is not an issue because we're in the retroperitoneal space. Things that really would push me off of doing a lateral approach would be any retroperitoneal surgery itself, or for instance on the ureter, or radiation to that area. I think I would probably just go to an all posterior approach.
Yeah, Ivan.
How far distally can you do this safely? Once you get towards L5, the approach is not quite straight. Plus, there's things like cardiac vein and structures like that which may limit some of the exposure. L5 is one, perhaps even L4 5.
Did you hear that question, Amir?
Now, could you repeat it? It wasn't coming over.
So Dr. Krabik is asking, how far distally have you done this? And I can say my experience has not, I've not done a lateral at 5'1". I know there are surgeons that do. I have done several at 4'5", and I've gone to a more of an anterior to psoas type approach there. And there are some patients where the psoas is just so large that you really have a difficult time getting there laterally at 4'5". But can you comment on that, the distal segments?
Yeah, so laterally I'll do up to 4 or 5. And one of the preoperative planning issues is the crest can be quite an issue in some patients, but other times there are angled instruments you can get around the crest. So a true lateral, anything below 4 or 5, I don't think is possible. People that are doing a lateral, typical, what we could call an OLIF, just with the patient in the lateral position, that's really just an ALIF with a slight variation on the approach. So you're still going between the vessels. It's basically just an ALIF in the lateral position.
Right. All right. Well, thanks again. I think we're going to have to move forward to stay on time here, but really appreciate your participation. I look forward to your talk here as we move forward.
My pleasure. Thank you.
You bet.